Early detection and documentation of community-acquired pressure ulcers, Stemming the Tide of Uncompensated Hospital Visits by Thomas W. Gallivan. A pressure ulcer is a phenomenon where the pressure between a surface and somebody's bones exceeds capillary filling pressure that blocks off blood flow. The result is an ischemic injury or lack of oxygen and tissue death. People at risk for this are the obese, diabetics, incontinence. The acid and the pH of your urine and feces breaks down skin. Muscle atrophy will lead to less cushioning between the bones. Hypertension, arterial and vascular insufficiencies, immobility, quadriplegics, and peripheral neuropathy. A pressure ulcer is the direct result of somebody laying in bed too long and not shifting weight. The impact on patients is about 2.5 million patients are affected annually. There is an increased length of stay added to each visit, along with the money and the costs to treat that pressure ulcer, along with maybe debridements, surgeries, more expensive dressings, and they're also very painful for patients. And typically, it's reported by the Agency of Healthcare and Research and Quality that about 60,000 deaths are associated with pressure ulcers every year. The cost to healthcare is staggering. It's estimated that $9.1 to $11.6 billion annually goes to pressure ulcers. It is estimated that of this, a pressure ulcer will cost $20,000 to $150,000 per patient. And there's an estimated 17,000 pressure ulcer related lawsuits with an average of $250,000 per settlement case. Centers for Medicare and Medicaid Services are no longer reimbursing healthcare facilities for hospital-acquired conditions, which includes pressure ulcers. And in 2014, the Patient Protection and Affordable Care Act will penalize the quartile of hospitals with the highest HAPU rates a 1% pay reduction on all Medicare patients, which could be an extreme amount if all your patients are on Medicare. Recent interventions for pressure ulcers include low air loss beds, Mepilex dressings, absorbent dressings, cushion dressings. We turn patients every 2 hours. We have barrier creams for incontinence, powders. We have a lot of interventions which have overall reduced pressure ulcer acquisition to about 3.5 to 4.5% in all hospitals. It is estimated by the Agency of Healthcare Research and Quality that if you take a 300-bed acute care facility with 15,000 annual admissions and a pressure ulcer treatment cost of $10,700, if you reduce the HAPUs by 1%, say from 4.5% to 3.5%, you can have the possibility of saving that facility $1.6 million annually. Also, if a pressure ulcer is not documented as present on admission, even if it was and the patient came in to the hospital with it, if it's not documented POA, the Centers for Medicare and Medicaid Services will not reimburse for that visit. Reducing that 3.5 to 4.5% HAPU rate is the goal of this research question. Does having a certified wound ostomy care nurse or other skin, wound, and ostomy team nurse whose sole focus is to inspect the skin on all patients being admitted into a facility, decrease the amount of uncompensated hospital visits as compared to the standard practice of leaving the skin assessment and subsequent documentation to the floor nurse. It is the purpose of this paper and presentation to explore the literature that is available on this subject to determine whether this is an ethical proposition. The literature reviewed goes like this. The first article was titled "The Impact of Nurses' Values on the Prevention of Pressure Ulcers" by Ray Samariwo. In this article, it was a subjective questionnaire that asked nurses to volunteer and give their opinions on how high a priority they gave to pressure ulcer prevention, and to discuss the attitudes of their colleagues about pressure ulcer prevention. The second article was "The Prevalence and Incident Rates of Pressure Ulcers in an Emergency Department" by Duguerat, Vidu, Fauer, Gabinski, Bordeaux, Marchesson, and Sals in the International Wound Journal, and it explored the what was going on in a very urban, high-volume emergency room, and how quickly patients were developing pressure ulcers, especially in a ED situation where there were no low air loss beds or hemopexes or skin assessments as usually done by a floor nurse. The third article was "The Accuracy, Completeness, and Comprehensiveness of Information on Pressure Ulcers Recorded in the Patient Record" by Thoroddsen, Sigurjonsdottir, Enfors, and Ehrenberg, in which it was explored that the accuracy and completeness of nurse charting on patients was unreliable and inaccurate, and that was the findings of that study. The fourth article researched was "Nurse Staffing and Post-Surgical Complications Using the Present on Admission Indicator" by Barbara Mark and David Harless. This article was selected for this paper because it included pressure ulcers along with thrombophlebitis, catheter infections, and some other prominent post-surgical complications. This article ended up dropping 3 of those post-surgical complications out of its research study, and actually found that there was no correlation between the increase in nurse staffing and a decrease in complications. In fact, they found an increase in complications, which they theorized was due to more staffing, more detection. The last article selected was "The Economic Evaluation of Pressure Ulcer Care, a Cost Minimization Analysis of Preventative Strategies" by Sherman et al. This document actually was a quantitative study that compared human interventions such as nurse aid turning every 2 hours, skin barrier creams, applications of foam pressure dressings, as compared to the dressings themselves, low air loss beds, which were considered technical interventions. They found that the technical interventions themselves cost less, but were mainly effective in reducing stage 3 and 4 pressure ulcers, whereas the human aspect, although cost significantly more, was more effective in treating low stage pressure ulcers like stage 1 and 2. But if you add this research article to the ED article, you will notice that most pressure ulcers that occur in the hospital-acquired pressure ulcers, are lower stage pressure ulcers. In order to implement the proposed solution, first what would have to happen is the data collection. We would need things like the current HAPU rate of a facility, Baseline data such as the number of admissions, the number of beds, how many people come in through the ED as compared to direct admits, and how many what the current pressure ulcer intervention costs are, supply costs, things for baseline data. Implementation would include creating a new position, clearly defining the expectations of that position, determining whether you would need a day shift nurse and a night shift nurse, or if you would need and weekend nurses for your facility. And then the third step, then you implement it and have somebody do it. And then you evaluate the data, record data the whole time. Were HAPUs reduced, or is there a savings, cost savings per the new position, or would it be more cost effective to just educate your nurse aides or get tighter regulations on documenting and assessing? Barriers to change that cropped up with this research pointed to a lot of environmental factors, such as the prioritization of the medication pass, doctor's rounds, and timely discharges or bed management, which took precedence over pressure ulcer prevention. Also, the delegation of skincare and incontinence tasks to the nurse aides. It was found in a lot of these articles that some of the nurses had never rolled their patient over to even know if they had a pressure ulcer and completely relied on the verbal communication of their aides. So that, there's also the question of the financial savviness of having a specialized position. Could it be more cost effective to have more frequent pressure ulcer in services? Would it be more cost effective to just do more chart audits with rewards and penalties for inaccurate charting and documentation? Or would more education for your assistive personnel be more a costlier intervention, and not passing off assessment, but teaching your assistive personnel how to better care for skin incontinence, elevate heels, turn, and the such. Changes of practice, whether this new position comes about or not, definitely points to the fact that increased reliability and completeness of nurse charting needs to be a priority. With increased reliability or completeness and accurateness, you can reduce HAPU rates or actually uncompensated hospital visits maybe completely. Pressure ulcer assessment and preventive interventions need to start in the emergency room. That was proven by that second article. Whereas, this ED nurses need to pay more attention, although they are just trained to do focus assessments. If they have a patient who's a boarder and they've done a Braden scale and they know it's a low score, then they can take steps to putting Mepalexis on, turning while they're still in the ED, or pay more attention to cushioning and blood flow and circulation of that patient. Thirdly, the empowerment and education of nursing aides to be skin champions definitely needs to be prioritized by hospital facilities, because that could definitely has the potential to be a very cost-effective way of reducing hospital-acquired pressure ulcers. The next slide is the references used for this presentation.